Hi guys, so today we'll be looking at the rapid revision for pediatrics. So I've split it into 3 sessions. So the first session, each session is will go on for probably 40 to 45 minutes. And all this time I was writing everything, so you wouldn't have able to hear my voice. So the 3 sessions we are going to have are going to be your first session where I'll be covering growth with growth chart, your development milestones, how to remember them, and then your immunization, your universal immunization schedule, your Indian Academy of Pediatrics schedule, and then a few points about important vaccines and acute events following immunization, and then finally about cold chain. The last thing will be about your nutrition, your macronutrition, micronutrition, yes, the deficiency of that, which is your SAM, MAM, your kwashiorkor, marasmus, all of those things. And then the second session, we will be looking at the various systemic problems related to pediatrics. So these are all very specific conditions which are very common in pediatrics and not focused in medicine, but it will be given in your medicine textbooks also, but in your pediatric textbooks, this will be the main topics of focus. So the first one is yours, congenital heart defects. Second, your GIT, you have some 4 or 5 topics in that. When we talk about GIT, I'll mention those. Then musculoskeletal, there's only one important one, which is your rickets. Then blood, you have various hemolytic conditions, and then your blood malignancies like AML, ALL, all of those will be there. And then when it comes to CNS, the most commonly asked question is febrile seizures, because it's very common. Second is your birth traumas and injuries, your hydrocephalus, cephalohematoma. All of these would be there in your obstetrics books also, but it's given more preference over here. And due to this, there might be neonatal jaundice, so we'll talk about that in newborns. Then you have cerebral palsy, which is an important case for us in a practical exam. Then you have various neural tube defects, like your meningomyelocele, meningocele, and then spina bifida and anencephaly. These 4 are the most important ones. Then going to your renal system, your nephrotic and nephritic syndrome are most important. Then you have an important malignant tumor over there, that is your Wilms tumor. Then your genital, you have cryptorchidism or undescended testis, it's common pediatric age group. And then your respiratory system, you have your respiratory distress, and then you have meconium aspiration, and you have cystic fibrosis. The last few important malignancies in pediatrics is going to be your AML, ALL, nephroblastoma, this is the other name for Wilms tumor, and neuroblastoma, which is a tumor of the adrenal gland. The last session will be a short session on newborns. So since this is a rapid revision class, I can't be going into the details of each and every topic, but I'll give you a hint based on which you can write answers easily for your exams. So let's start off with growth. Okay, growth and development. We'll club these two together. So growth is the increase in the number of cells or the size of cells. Okay, there's a physical increase in number of cells like bone density, somatic growth. That is what they that's what they mean when they say growth. When they say development, it's related to the maturity or differentiation of the cell. Okay, just because there is a lot of cells over there, it doesn't mean it's developed. Developed in the sense it differentiates or it matures or it develops certain processes within the cell which allow it to carry out specific functions in our body. So that is your development. So growth and development are 2 different things, but they help in understanding the how a child grows into a man or woman, or all of those can be explained with these 2. So there are various parameters for growth. The most important ones are your weight, your height, your head circumference, your chest circumference, your mid-arm circumference. These would be all. Okay, these are all the various measurements you will be looking at in a child to comment about his or her growth. So there are some various formulas. For example, the usual weight of the baby is going to be 2.5 to 3.5 kg, and then for first 3 months is going to gain 20 to 40 grams, 20 to 40 grams, and then it's going to double its weight in 6 months, and then triple its weight in 12 months. There'll be one table over there. So these are all something which you need to know. Just remember the basic stuff, that the weight doubles in 6 months, and it triples in 1 year, and then 4 times in 2 years. So that is enough about weight. And then for height, the normal height is 45 to 50 centimeters length. So the length is when the baby is like lying down. Okay, so that is length of the baby. And when he is standing, he or she is standing erect, that will be your height of the baby. So height, again, you have some 2.5 centimeters growth per month or something like that. And then this will go in a pattern like in 1 year, you will have 75 centimeters. In 2 years, you will have, so half of 50 is 25. You add that to that, so plus 25. So plus 12.5 plus 6.25. So that's how your progression will be there for height. So that's a small trick which you can figure out if you look at the table over there. And then head circumference, it's usually when the baby is born, the head circumference is equal to your chest circumference. But in 3 years, your chest circumference will start becoming big, and that is how you know that the chest circumference will initially be less than the head circumference. In 1 year, it will become equal, and in 3 years, it will start becoming bigger than the head circumference. Head circumference is usually 34 centimeters, normal value. Okay, and last one is midterm circumference. So this is an important thing for finding out the severe acute malnutrition, the nutrition status of a child. So you use various equipment like your inch tape. There's something known as Bangle Test, where you have the examiner using a bangle of certain size, 4 inches, and then you check if that is passing through the baby's hand. And then you have stick, quark stick, and the most important one is Shakir's tape. So Shakir's tape is like one tape like this, but there will be one green area over here, yellow area over here, and red area over here. So your green is greater than 14 centimeters, your yellow will be 12.5 to 14, and your red area will be less than 12.5 centimeters. So if it's in red, that means that the child is in severe acute malnutrition, and you need to like supplement that child with enough nutrition over there. So that is about your mean midterm circumference. And the most important thing is you look at this for the first 5 years. After this, the midterm circumference is not of much use, because it's the tissue in our arm is slowly gets replaced by muscle. So that is something which you need to know. That's why it's important for the first 5 years. And then that would be all about your growth parameters. Your development, you have development milestones. So you split it into gross motor, fine motor, your social, adaptive, and your language. Okay. Now there are going to be slight variations depending on which source you're going to use for all of these development milestones. So I'll give you a general idea of how this thing is generally set up. Okay, you take this is a child. So the important laws of development are that it occurs from head towards the foot. So initially you will have neck raising, then chest raising, and then hip raising, that is rolling over, and then the child will be able to sit, and then stand with support, then stand without support, and then start moving, walking, jumping, tricycle, and then climbing down the stairs initially, then up the stairs. So those are all your gross motors. Okay, so the most important thing is 1 year, you remember. 1 year, the child should stand with support, and within 1.5 years, the child usually walks on his or her own. So these two are the most important ones. Other ones you can just give a rough thing like in 2 months he'll be able to raise his head. In 3 months he'll be able to raise his neck. In 4 months he'll be able to raise his chest. In 6 months he'll be able to shift from prone to lying, and then in 8 months he'll be able to sit with support, and then in 9 months he'll be able to sit without support. All of those you can fill it up. This is not perfect, but it makes life so much easier when you do it this way. So this is how I would remember this. And then moving on to your fine motor. Fine motor, you have something known as your primitive reflexes. Okay, the most important one being your grasp reflex. That is, the hand will be flexed per se. This will go away by 6 months. So two important things which you need to know are your pincer grasp. Okay, so you have immature pincer grasp and mature pincer grasp. Okay, so your pincer grasp, it usually develops in your 8 to 10 months, and mature 1 year. So what this mature and immature is, see, when the baby uses the whole of his palm and fingers to pick up an object, that is your immature pincer grasp. When he uses only 2 fingers like a thumb and index to pick up an object, that is your mature pincer grasp. Okay. Then other than that, you have your mnemonic Lockstead. So 2, 3, 4, 5, 6, 7. Just put that over there. So 2 line, 3 circle, 4 cross, 5 square, 6 triangle, and then 7 diamond. So those are all your fine motor findings over there. Okay, and then there will be other things like tower of blocks, building 2 blocks, and then 9 blocks, then bridge shape. All of those are extra points which you can add for fine motor skills. And then social adaptive. Okay, social adaptive is how the baby interacts with the strangers and the environment. So in 2 to 3 months, he starts identifying objects and following objects and identifying his mother and all. So within 6 months, he develops stranger anxiety. Okay, and then 8 to 10 months, he starts imitating, and then 12 to 15 months, he starts like listening. He starts writing on his own like that. Okay, then 2 years, he starts individual play. 3, 4, 5 years, he starts parallel play and group play. So these are all your socio-adaptive markers for development. And then the last one is language. So for language, again, you put your thing as 1 year, 1 word. Okay, this is normal. So before 1 word, what are the things you're going to say? Jargon, babble, bisyllable, cooing. Okay. Then after 1 word, you just put 3 words, 1 sentence, and then asks questions, understands meaning of words. Okay, that is your language milestones. So there's one important thing known as development quotient, or DQ. So what you do is you divide the age at which that milestone appeared, for example, neck holding, divided by the normal age where that thing appears. So if you have 70%, less than 70%, then it's a developmental delay. So you can say this as an extra point when it comes to your development milestone. And then there's one important thing known as growth charts. So you have 2 important growth charts, IAP and your WHO. So WHO is for neonates till 5 years. Your IAP is 5 to 18 years. So what they will do is they will have a plot like this. They'll have one center line like this, two lines like this, last line like this. So this is your midpoint. This is 1 standard deviation, minus 1 standard deviation, minus 2 standard deviation. This is plus 1 standard deviation, plus 2 standard deviation. So this is usually considered as normal. So within this, I'll highlight it in pink color. So when the baby's any measurements are within this area, it is usually normal. When it goes beyond in this area, it's abnormal and it needs workup. Okay, so when they ask anything about this growth or development, what you need to do is you can mention all of these points. These are like basic for your practicals and your theory. Other than this, you can mention about the laws of growth. That is, it happens in the sequence of events never changes. Only the time duration in between events may change. And then cephalocaudal thing, and then various somatic growth is different, lymphoid growth is different, your gonadal growth is different, and your brain growth is different. All of those points are extra points which you can add when it comes to your growth and development. The important questions which they're going to ask are going to be short stature, failure to thrive, and short stature, failure to thrive. You have microcephaly and macrocephaly. Okay, with a little bit of common sense and all of these points in extra, like they ask you about short stature, you say it's your physiological and pathological, and then you say you need to first assess the child's growth. To assess the child's growth, I'll look at his weight, height, head circumference, chest circumference, mid-arm circumference, and then I'll come to a conclusion about and plot it against this growth chart and see his status. And then if it's coming less than -2 standard deviations, then I will go investigate further. The various reasons for short stature are going to be either nutritional, genetic, or some kind of growth hormone deficiency, or hypothyroidism, or some kind of psychosocial short stature. All of these are the points which you can say. Same thing is for failure to thrive, where the baby doesn't gain weight. Short stature is height is less, failure to thrive is doesn't gain weight. Microcephaly, macrocephaly is micro is when you have less than -2 standard deviations, and macros greater than 3 standard deviations. So again, we split this into, like, is the baby having only size of the brain difference or some kind of pathology in that, so some mental retardation, all of the symptoms. So you have primary and secondary, macro, micro, and then you have some syndromes like Apert syndrome, and then Crude-Chat syndrome, Noonan syndrome. All of those will cause this micro and macrocephaly, and then there are different types of cephalies, and also that's a short note, just go through those. So that will be all related to your growth and development, and next we'll move on to immunization. Okay. Don't worry, I won't be telling the whole universal immunization schedule and your Indian Academy of Pediatrics schedule, but I'll give you certain points which you can write for any vaccine which they ask about. Okay, so these are the points which you can use for any vaccine, no matter what vaccine they ask. So usually it is going to be 0.2 to 0.5 ml, okay, or 2 to 4 drops. This is going to be the amount of vaccine which you're going to give, and usually it is in the muscle, your right deltoid or your left deltoid and your gluteal region. Okay, so these are the common areas where you're going to administer your vaccine. And then cold storage. Most of the vaccines are stored at 2 to 8 degrees centigrade. So this is another point. And then AEFI. So certain vaccines have special adverse effects which you need to know. Like your OPV and IPV had some problem with them, and it caused more harm than doing good. So there are some special things, but I'll give you general ones like your normal rashes, burning sensation, and then nausea, vomiting. All of these you can mention for all of your vaccines. Other than that, your specific points are going to be your type of vaccine. So it can either be a inactivated or live vaccine, or it might have some toxoid containing vaccine. Okay. And then when it is administered. All right. These are all the common points which you can use for writing almost any vaccine. Some of the important vaccines are going to be your oral polio vaccine. Add a bit before that. So bivalent oral polio vaccine and IPV, injectable polio vaccine. This is very importantly frequently asked questions. And then you have your pneumococcal vaccine. This is an adult vaccine where it's given seasonally. Other than that, the common vaccines which you use are your Hep B, and then your BCG, your HIB, your JE, and then your rotavirus. These are all the common vaccines which you need to know. So I'll give you a small trick for remembering the immunization schedule. So at birth, at 6, 10, 14 weeks, and then you have 6 to 8 months, 10 months, 12 months, 2 to 5 years, 8 years. Okay. So you focus on these three areas alone, okay, because these are commonly asked questions, and they'll be asking this in your Viva. And once you start off telling your vaccination schedule, they're not going to wait till you complete it and all. If they know that you know some part of it, then they'll believe that you'll know the rest of it also. So I forgot to tell an important point about these vaccines. So there is one thing called vaccine vial monitoring policy. So they have one box over here with some patch like this in between, and then when that patch becomes like so big and you can't see that circle, that means that vaccine has expired and you can't use it. So that is something which they ask in the Viva, and you can use that also. And then the last topic is nutrition. So for nutrition, it's enough if you know the common macronutrition, micronutrition, and water. Okay, you can relate most of pediatrics into these three things. So your macros are your carbs, proteins, and fats. So carbs, energy, protein, building, fats, hormones, and then like storage for in case of you don't get any food. And then your micronutrients, you have your vitamins. The important vitamins are your vitamin A, vitamin D, and then vitamin B complex. You can club it all together over there. And then other than that, you have your zinc, magnesium, other important minerals which you need to know about, and water. So what you need, if they ask anything about nutrition, you should talk about the 24-hour recall method, where the patient recalls how much and you do calculation of calories and protein intake. And if there's any deficiency, then you need to adjust accordingly. So what is going to happen is you have two conditions, MAM and SAM. So MAM is -2 to -3 standard deviations. SAM is more than -3 standard deviations. So the child is going to have all kinds of nutrition deficiency. Okay. So what are the deficiencies you have to specifically know are your protein deficiency is going to cause muscle wasting, and then your iron deficiency. So that has some special like koilonychia and sparse brittle hair, and then white hair. White hair is B12 deficiency, and then so So you just integrate all of those points into that, and the management of SAM is very important. You have 10 steps. So first you need to correct hypoglycemia, and then before refeeding, you need to check his electrolytes, his glucose electrolytes, and then you need to start refeeding. While refeeding, you have your starter 75 and starter 100. So it's nothing but 75 calories they're going to get from that diet and 100 calories. So that has one normal split up of various food items which has so much calories, some milk, some 1 cup of rice, some 1 teaspoon of oil, all of those will be there. It has 75 calories and this will have 100 calories. So that is your catch up, and then monitoring of that and refeeding. And finally, you give education and you send that patient home. So there will be 10 steps given in your OP guide. So you can go through them. But logically speaking, just first emergency things like your hypoglycemia, electrolytes you balance. Then you start refeeding. And then you check if that baby is recovering on all of that. And then finally, you educate the patient and you send that patient home. So that will be the end of the first session. I'll take a small break and we'll start the second session at 11:50. Okay. Okay, guys. So let's continue. In this session, we'll be looking at the various systems and the important questions for each system in pediatrics. So let's begin with CVS. Okay. So when it comes to CVS, we've already studied in medicine about the various valvular defects and your heart failures, and then your ECG abnormalities, your arrhythmias, and all of those. In pediatrics, you're going to only focus on congenital heart defects. So if you want proper understanding, I recommend you go through embryology of heart. Okay, so you will have your primitive heart, your truncus arteriosus, and then your bulbus cordis. All those will separate, and then you have an interatrial septum, interventricular septum development, and fusion of septums. All of those. So it's very beautiful, but I don't have the time to explain all of that. So congenital heart diseases, we'll be splitting them into cyanotic and acyanotic. So your cyanotics are going to be your 5 T's. Okay, everyone knows it's 5 T's, but they don't know what the T's are. So the 5 T's are, you remember, like 1, 2, 3, 4, 5. Okay. The first one is going to be stenosis. Okay, I forgot what stenosis this is. Then second one is TGA, transposition of great arteries. Third one is tricuspid stenosis, and then the first one is persistent truncus arteriosus. Okay. Second is problem in 2 vessels, your great vessels, your pulmonary artery and your aorta, that is your TGA, transposition of great vessels, and then you have tricuspid atresia. Then your TOF, tetralogy of Fallot, and 5 is total anomalous pulmonary venous return. Okay, TAPVR. So the most important one in this is going to be TOF. For TOF, you have 4 components. Okay, the first component is your VSD. You have the first one is pulmonary stenosis. Due to that, you have a VSD for shunting of blood, and then you have right ventricular hypertrophy, and the last one is overriding of aorta. These are the common symptoms for TOF. So the common points for all of these are going to be, see, they're all cyanotic diseases, right? So you're going to have cyanosis, cyanotic spells, and something known as squatting or breath holding. So what this is actually, it increases the peripheral return from peripheral resistance, thereby increasing the pressure in the left side of the heart. I'm not going to go into the detailed mechanisms, but just remember that this is a compensation mechanism in case there's some kind of heart failure leading to cyanosis. This, if the kid does this, his heart goes back to its normal for some time being, and then it becomes all right. So for most of these conditions, you're going to do surgeries, okay, and you're going to correct the defects. And then other than that, your heart failure symptoms, and then your reduced ejection fraction, your right-sided failure, left-sided failure, persistent infections, and persistent respiratory tract infections and failure to thrive are common symptoms of CVS abnormalities. Next one is your acyanotic heart disease. So acyanotic, you have VSD, ASD, and PDA. Okay. For all of these, you have specific murmurs. So for VSD, you have pansystolic murmur. For ASD, you don't have any murmur, but you have split, extended split of S1, S2, and then PDA, you have continuous murmur. So for all of these, it's very simple. You just draw a box like this. So you have your right atrium, left atrium, right ventricle, left ventricle. So your VSD is, this is your ventricular septum, right? You have a hole over here. This is your VSD. You have a hole over here. This is your ASD. Okay. Your patent ductus arteriosus is, let me tell a little bit about fetal circulation before I go into this. So you have your umbilical vessels coming over here. You have your liver over here, and then you have ductus venosus, first one over here. From this, you have portal vein and goes to the heart, IVC, and then heart. In your heart, you have this foramen ovale, that is your second one, and then you don't have mature lungs, right? So from your pulmonary artery, there's one bypass to the aorta, that is your third, your ductus arteriosus. So this patent ductus arteriosus is a problem where this thing is persisting. So other certain points is prostaglandins. Okay, they help in maintaining opening of these. So you give prostaglandin inhibitors to close these communications, and the most important one is indomethacin. Okay. Other than that, complication of acyanotic heart disease, you can mention this Eisenmenger syndrome. So what Eisenmenger syndrome is basically your reversal of shunt. So usually the blood flows from high pressure to low pressure, right? So the left side of the heart is usually the high pressure state, but in case of Eisenmenger syndrome, the right side becomes high pressure and the patient starts to develop cyanosis. So that is your Eisenmenger syndrome. Other than this, there are like the questions which you have already seen in medicine, like your rheumatic fever and infective endocarditis can also be asked from CVS. So we'll wind up CVS with that, and then we'll move on to GIT. So we'll move on to GIT. So various important topics in GIT are going to be: one, your tracheoesophageal fistulas; two, pyloric stenosis; three, necrotizing colitis; four, Hirschsprung disease; The last one, neonatal jaundice. Okay, so of this pyrorexinus, they already asked in one of our papers. This is a little bit rare. So we'll focus on tracheoesophageal fistulas, Hirschsprung disease, and neonatal jaundice. I'll talk about in your newborns. Okay. So tracheoesophageal fistula, you have your trachea, esophagus behind and trachea forward, right? So there's going to be abnormal communication over here. So there are around 5 types of tracheoesophageal fistula. The most common one being there's a blind pouch over here and connection over here. So it will be like this. Okay. So that's the most common type. So the problems are going to be aspiration, and then in any GIT problem, right, you're going to have decreased nutrition. So when you have decreased nutrition, you will have your nutritional deficiency symptoms like as in SAM and MAM. So you integrate all of those points in case you run out of points to write any problems in GIT. And then that is about your tracheoesophageal fistula. Then how do you do diagnose? This is endoscopy, where you won't be able to go beyond the blind pouch, and then you can do an X-ray, barium meal, and then treatment is going to be surgical only, surgical repair. Okay, so that's a tracheoesophageal fistula. And then Hirschsprung disease, you have the various layers of abdomen, right? So this is your mucosa, this is your submucosa, this is your muscle, and this is usually your peritoneum area. Okay. So you have 2 plexuses over here. Your submucosal plexus and your submyenteric plexus. So this is Auerbach and this is Meissner's. So they are known as the brain of the gut, and they help in peristalsis and movement of food. So when these two are not functioning properly due to infection or congenital conditions, then there won't be movement in that part of the GIT system. So again, nutritional deficiency, and then dilatation of the GIT before that, and then constipation, and then there's something known as blast syndrome, where you do a perirectal, then there'll be so much feces coming out. All of these are the points for Hirschsprung disease. Again, the treatment is going to be either a colostomy, or you're going to do a colectomy and anastomosis with the sigmoid colon, and you make sure that that bowel is functioning properly. Other than this, the most important question is going to be your diarrhea. So diarrhea, again, you have your simple diarrhea, your persistent diarrhea, and then your chronic diarrhea. There are various definitions for all of these. So many reasons are there, like bacterial, viral, protozoal, and then any kind of food allergies, and then iatrogenic, and then psychosocial. So many are there. You can write so much stories when it comes to gastritis. Again, important thing here is dehydration. So dehydration, you have IMNCI classification. No dehydration, some dehydration, and severe dehydration. So A, B, C. So A is fluid replacement, and B is you give ORS, and finally C is IV fluids. So you give, I'm not sure about the values, but 20 to 50 ml per kg, half an hour you give in 2 hours, I guess. And then you check the fluid status, and then you do it again. There's one treatment algorithm for this, so please have a look at it. That is your plan C. So no dehydration, like signs of dehydration are going to be your skin turgor, your sunken eyelids, and your thirst. So if all of these are present, and then that is going to be some dehydration. Severe dehydration is the baby won't be you won't be very enthusiastic to drink water, so it's very dehydrated, and skin turgor will be very prominent, and the sunken eyelids can be seen prominently. So those are the signs of dehydration, and I'm in CI for dehydration. So that'll be about your diarrhea and dehydration. So we'll move on to the next system. Next system is musculocutaneous. So you have your rickets. We would have already studied this in our orthopedics. So rickets, type 1, type 2. So calcium related, phosphate related, vitamin D supplementation, phosphate supplementation. Other than this, there are some rare causes like your renal tubular defects, and then in renal tubular you have your reabsorption, secretion problems. All of those are some extra details. So what happens is bowing of legs, bossing of fontanel forehead, and then you have epiphyseal widening. All of these are various signs which you see in rickets. So other than that, you give about 1 lakh units vitamin D supplementation, and then make sure he gets adequate sunlight and exercise and all of those things you can mention when they ask about rickets. So that will be, they already asked this in our ortho exam, I guess. So just go through them. I'm not sure if they'll ask or not ask, but it's common in children, so might as well go through them. So for CNS, you have your febrile seizures. So you would have already seen this as epilepsy in your medicine paper, but some important points are it can be either related to some kind of genetic condition or some fever in your childhood, like your meningitis in childhood. All of those are going to cause seizures. So febrile seizures is where there is increased temperature, and due to that the baby is going to go into seizures. It's not recurrent, and this doesn't predispose the baby to develop epilepsy in the future. But the way you treat this is you reduce the inflammation, that is the temperature, by giving NSAIDs. So the important thing is you don't give aspirin. Okay, you can give paracetamol or some other NSAID, but you don't give aspirin because of Ray's syndrome. So Ray's syndrome is hepato and encephalopathy due to aspirin intake. So that is your Ray's syndrome. Your triad of hepatic damage, encephalopathy, and aspirin intake is your Ray's syndrome. You give paracetamol like that to treat it, and then you educate the patient's parents saying that this is not recurrent and it's not a big problem and you don't have to worry about it. All of those things is your febrile seizures. Then next is your birth trauma related. You have seen this in OG. So you have a hydrocephalus and cephal hematoma. So hydrocephalus is usually not a problem due to some birth trauma. There's collection of fluid in the scalp, and cephal hematoma is collection of blood. This is not dangerous per se, but because of this, that child can develop neonatal jaundice. That's an important point over there. You don't need to treat this per se. You need to wait and watch. So there's one more thing known as caput succedaneum that is very dangerous. So that requires urgent care and attention, where there's like collection of blood within the brain. So other than that, these two are fine. And then your cerebral palsy is how it's defined as damage to the developing brain leading to motor neuron defects. So usually it's going to be a spastic or a paralytic type. So you have both of them. Spastic is most common. So this can be due to various preterm labor, respiratory distress, and then maternal infection in pregnancy, and then your meningitis in childhood. All of these are predisposing factors for cerebral palsy. Anything which affects the growth of the brain in the first few years of the child is going to cause cerebral palsy. So the two types of spastic and paralytic palsy are there. So you're going to see spastic, and then you talk about your your descending tract, where you have your motor cortex coming from your precentral gyrus, and then your it crosses at the medulla, below the medulla, and then goes down and reaches it. So upper motor neuron type of lesion, lower motor neuron type of lesion, then differential diagnosis for various conditions. And then you can write a whole lot of this, and you've already seen this in your case, so I don't want to waste a lot of time in this topic. The important topic is neural tube defects. So neural tube defects is you have your spinal cord formation over here, right? So there can be a problem here or here. So here there can be three problems. So the first one is spina bifida, like you have a spine like this. This is spina bifida. It can be seen as tuft of hair, and then neurocutaneous marker. So any neural tube defect, talk about folic acid and neural tube formation. Your nuchal translucency scan can be used to detect all of these. So your spina bifida. Second one is meningocele, where only the dura, that is the meninges are herniating, and then meningomyelocele. So this is where the part of spinal cord plus meninges herniate. You have an important syndrome over here known as Arnold-Chiari formation or Arnold-Chiari syndrome. This syndrome is related to this meningomyelocele and hydrocephalus. So based on that, if they ask this syndrome, then you write based on this, go to folic acid, neural tube formation, and your nuchal translucency scan, and all of those. Use that, and then that will be all about your CNS. So renal nephrotic syndrome, again an essay asked. So nephritic is inflammation, so hematuria, cola colored urine, and then decreased urine output, decreased protein in urine. All of these are important symptoms and signs of nephritic syndrome. So most common is PSGN, post-streptococcal glomerulonephritis, and then you have your Buerger's disease, which is your IgA related problem, and then these two are then you have SLE mediated nephritic syndrome. So these are various causes of nephritic syndrome. And then your Wilms tumor is again malignancy of renal thing. So you have a mass in the flank, behind lower flanks of your abdomen, and then usually this doesn't cross the midline. Your neuroblastoma will cross the midline. I'll talk about this when we talk about malignancies. And then cryptorchidism is, we have seen this in surgery. So undescended testis. So your testis develops over here. It moves via the inguinal canal and reaches the scrotum over here. So it can be stuck over here. So the main problem with this is if both are stuck in between somewhere like that, child can become infertile, or that the testis can become malignant. So what you do is orchidopexy, where you bring the testis back to its original position, or you remove the testis. So these are the most things for genital. And then your last important thing is your respiratory system. So all of these will come in your newborn again: respiratory distress, meconium aspiration, cystic fibrosis. Other than that, you have your pneumonia or consolidation and bronchiolitis. So these two you would have already read in medicine, so no need to go into these. Respiratory distress, meconium aspiration, and cystic fibrosis we'll talk about in detail. These two we'll talk about in newborn. We'll talk about cystic fibrosis. So cystic fibrosis, this is the gene related to cystic fibrosis. So it's related to chloride channel, and there is reduced motility. Okay, there are so many cilia, right, in your bronchus, in your fallopian tube. All of those are going to be affected by this cystic fibrosis. So there's going to be a decreased motility. So your defense mechanism, the main physical defense mechanism, is down. So because of this, you have upper respiratory tract infection, lower respiratory tract infection, all of those things. Important test for this is your chloride skin test. So you put a drop of water and check for chloride or something like that. They do, and they can find for cystic fibrosis. And then this is genetically predisposed by this CFTR gene, some delta 609 portion. And then you go into respiratory diseases in detail when they ask about cystic fibrosis, upper respiratory tract, lower respiratory tract, your pneumonia, then you have inflammation, and then cough, breathlessness, fever, fibrosis. All of these stories are already seen in medicine, so you just bring all of those in. And lastly, we have to look at the important malignancies. So AML, CML, they already asked CML in blood, so based on that, you know what is going to happen. So blast crisis, they asked in medicine paper, right? That is going to be similar to your AML. So nothing big over there. Your nephroblastoma is Wilms tumor, neuroblastoma is adrenal tumor. So adrenal gland is responsible for producing your epinephrine, norepinephrine, dopamine, all of those. So important markers for this is going to be your vanillic malinic acid and homomalinic acid. So these are basically the breakdown products of adrenaline and noradrenaline. VMA and HMA, just go check the correct names of vanillic malinic acid or something like that will be there. So these will increase in case of neuroblastoma. So you want more integration, think of pheochromocytoma. Similar to that, but no sweating, all of those symptoms, but similar physical findings will be there. And this can cross the midline, has to be surgically removed. Nephroblastoma doesn't cross the midline, and it's related to various syndromes. There are some 3 syndromes, some Becker syndrome and GARV syndrome or something like that. I'm not able to remember those 2, but it's associated with that, and this also has to be removed surgically, otherwise it's going to cause a problem, and it's going to be confined to the midline. So you can take a CT scan to find it out, and there'll be a mass in the lower back, like the kidney area, Molson's parallelogram, that area. And that will be all for this session. So the last session will be about your newborn. So we'll have that session at 12:30. Okay. Okay, let's continue, guys. So the last thing we'll be looking at today will be your newborn. So when it comes to newborn, there are a basic set of terms which you need to know. One is your preterm, and then that is when the baby is given birth before 37 weeks. And the most important thing here is your lung maturity. Okay, and then you have normal body weight is going to be 2.5 to 3.5 kgs. Your low body weight is going to be 1.5 to 2.5 kgs. Your very low body weight is going to be 1 to 1.5 kgs, and your extremely low body weight is going to be less than 1 kg. Okay, these are all some important terms which you need to know. And then important thing is going to be your ABGA score. So this includes your attitude of the newborn, the respiratory effort, the color of skin, and then activity, So based on this, you can say that the fetus has transitioned into from intrauterine to extrauterine, and it's come out pretty good. So APGAR score of less than 7 is going to be, you need to give some kind of resuscitation or some kind of care over there. Of 9 is usually fine. Okay. You check it at immediately after birth, and 5 minutes, 10 minutes after that, you keep checking until the baby becomes all right. Some few other scores are, you have your newborn neuro and musculoskeletal assessment. So this is based on the joints. Like if this is the baby, then if all joints are flexed and wrist is flexed, then the baby is like properly developed. And in case there's no flexion and the baby is not crying and all of those things, the baby is not developed properly. There are some various gradings, some 6, 5, 5 gradings and all. I'm not going into the details, but basically based on the joint positions and the various activities of the baby, you will see if the baby has developed or not. The last one is your New Ballard score, or this is also known as New Ballard score. So that is another criteria based on like all of these, and you have your reflexes. Based on that, you just examine the newborn and you go through this, like you see if it's grown properly or not. Okay. So there are some primitive reflexes. So the primitive reflexes are your grasp reflex, Morose reflex, Landau reflex, and then your Morose reflex, also known as parachute reflex. You have your glabellar tap, then there are a few more reflexes. I have sent an image for this, so go through those. These are normally present at birth and it's completely normal, and usually by 1 year all of these reflexes are usually gone, but in case of CP or something like that, you see the persistence of reflexes. So that's about your newborn general examination. Okay. Important things are your physical examinations. You have various findings for your Down syndrome and your cyanotic heart diseases and all. So you can, like cleft palate is common in Down syndrome, low set ears, and then hypertelorism, distance between the eye, the inner canthus of both eyes will be thing, and then short webbed neck and Turner syndrome, and then all of those. And preterm babies, there are going to be certain findings like your testis won't be completely developed and the rugosities won't be visible. Then the nipples will be barely, nipple and areola will be barely visible. The hair will be sparse, and then the baby's skin will be like flushed, and then the ears won't be completely developed. So, and the creases won't be visible. So all these are signs of preterm baby. Normal babies will have creases, and then nipple areolas will be proper, and then your testicular rugosities will be present. All of those are points in favor for normal newborn birth. So important topics in newborn are going to be your respiratory distress, and then meconium aspiration syndrome, and then you have your hypoxic brain damage. So that is an they can ask that question. All of these will be the action will be similar. Then you have neonatal sepsis, and you have neonatal jaundice. Okay, so these two are related to your respiratory system. So here you have a problem with your surfactant production. So surfactant is required to maintain the surface tension of the alveoli, and the compound here is dipalmitoyl phosphatidyl choline. So there's a defect in this, and that leads to respiratory distress. So how this presents is like breathing difficulty, and then eventually you will go into cyanosis, hypoxia, all of those. and then the baby will eventually die. So you have neonatal dissociation protocol here. So before we go into this protocol, I'll just tell a little bit about meconium aspiration. So when baby is in the uterus like this, okay, so it passes meconium, and the good obstetrician can easily detect presence of meconium in the amniotic fluid. And if this meconium enters the baby's stomach, mouth, and goes and gets dislodged in the respiratory system, you have meconium aspiration syndrome. Similar thing, but there it's surfactant, here it's meconium. That's the only difference, but similar complaints. And neonatal dissociation you're going to get. So neonatal dissociation, first you will check the breathing rate, SpO2, and your heart rate. So first you will check for a breathing rate, movements, and skin color. Okay, based on this, you will give if it's less than 90% SpO2, breathing rate is very less. In a normal infant, up to 60 it's normal. 1 year it becomes 30. So in between 6 months you put it as 45. Okay, these are normal breathing rates. So if it's not there, then you give artificial bag and mask ventilation. And then while you're doing this, you check for heart rate, and you check for your capillary refill time or cyanosis, for signs of heart rate, and you check for cyanosis. If heart rate is 100, then you don't have an issue. If it's less than 100, then you start giving CPR with one thumb CPR you give, and then you give, along with that, you give bag and mask. So if the heart rate is, and you switch over to positive airway pressure, all of these, and then if all of these fails, finally you will go to your adrenaline and epinephrine. Even after all this, the heart rate doesn't increase, then you take all of this. This is a rough algorithm. This is not perfect, so please go check your textbooks once. But the concept is, you check the breathing respiratory system, make sure it's all right. You supplement it, and then check the cardiovascular system, supplement it. If you're not able to supplement, use drugs, and then take care of the baby. So that is all about your neonatal dissociation. Then neonatal sepsis. This is closely associated with the maternal obstetric infections like your Torches infection. So toxoplasmosis, and then rubella, your cytomegalovirus, herpes, HIV, and syphilis. All of these can be transmitted from the mother to the child, and they're going to have certain signs like conjunctivitis, and then white discharge, fever. All of these things are going to be your problems with neonatal sepsis. And then any kind of sepsis, you're going to use antibiotics, usually ampicillin, ceftriaxone. So the dose will vary for pediatric group, but just know that will be your neonatal sepsis. Already, again, frequently covered topic in obstetrics, so I'm not going into detail. So last one is neonatal jaundice. There is physiological and pathological jaundice. So physiological jaundice can be due to birth trauma, or it can be your breast milk jaundice. And then there is one more, breast milk jaundice and breast feeding jaundice, I guess. Okay, most of the physiological thing is due to reduced UGP. glucuronidase. So this is the one which will transfer your amino group into your bilirubin, and it helps in formation of conjugated bilirubin. So this plays a role in that. If there's a problem in that, it's going to be causing jaundice. So usually physiological jaundice, you draw a baby like this. There's an important rule over here known as Kramer's rule. So unto the nipple 10 milligrams. So here and all, if it goes 40 milligrams like that. So anything above the nipple you can consider as physiological and weight, and anything below the nipple you're going to go as pathological jaundice. Physiological jaundice is going to occur in within the first week, 7 days, and it will subside within 10 to 14 days. But pathological will be there since birth and will be persistent. So the various pathologies can be some kind of enzyme deficiency. So your conjugation enzyme deficiency, like your Dubin-Johnson syndrome, Crigler-Naga syndrome, your Rota syndrome, and then these three are the ones I remember. So that will be increased in conjugated and increase in unconjugated bilirubin. So conjugated bilirubin, when it increases, you have your increased bile salts and their pruritus, and then high colored urine. All of these going to be signs of increased conjugated bilirubin. Increased unconjugated bilirubin is pale stools, and it can lead to kernicterus because unconjugated bilirubin can cross the blood-brain barrier and cause like encephalopathy kind of damages. So that's a problem with unconjugated bilirubin. So how do you find? You use your Coombs test, Coombs direct and indirect, for detection of this bilirubin, and you do the treatment options for this are going to be your phototherapy is going to be your main. You need to cover your eyes of the child and the genitals to prevent the radiation damage. So the radiation isomerases the bilirubin and breaks it apart and can be easily like reuptake by the baby. So other than that, that's the main treatment per se. Other than that, to prevent that cerebral edema, you can give. So yeah, so I just remember phototherapy. There are 2 more treatment modalities which I'm not able to recollect currently. So that will be all about your newborn. So I hope I've gone through most of pediatrics, all the important topics for you guys, and I hope you found this session useful. Thank you.